Hi there, everyone. I'm Andrew Jones. I work in the research and policy team at the strategy unit. The material I'm going to cover here comes from a piece of work Stephen White and I did for the Midlands and the Southwest decision support networks. I've had to be reasonably selective about what I cover here, but we should be publishing both full reports in the next few weeks. So what are community health services? I'll use the term community services to refer to healthcare services led by clinicians, which are primarily delivered to people in their own homes, but they can also be provided in community health centres, clinics and schools. So this is Jill, she's 68, and she was diagnosed with COPD about 10 years ago. Now she's recently had an exacerbation of symptoms, and so she has weekly visits from a nurse to monitor her condition and help with tasks like replacing her oxygen. But she also has been visited by a physio who can give her positioning and breathing exercises. Now, community services provide about 8 million contacts to people like Jill each month. But here I'll be looking at the 60% of contacts provided to people over 65. These contacts improve the quality of life for patients and their families and carers. And they can also keep the health system working effectively, but I'll look at this a bit later. And just for reference, community services as a whole account for £10 billion of the NHS budget and 1/5 of the total NHS workforce. So they're an invaluable and sizable part of the health system, and yet they're often overlooked. And there are several reasons why this might be the case. For one, these services actually have few visible hubs like hospitals or general medical practices. As I've said, most contacts actually take place in people's homes. And they can be difficult to define. So we have overlapping terms like intermediate care, transitional care, and hospital at home that may have contributed to a lack of understanding. But it's also the case that national data on activity and quality and spending for these services is limited. So analysis of these services can therefore be a challenge, and so attempts to seek funding or raise the profile are thwarted, and then in turn, data sets remain comparatively underused and underdeveloped, and we have this negative feedback loop created. Now, this brings me to the infamous CSDS, which is, as Rachel said, Community Services Dataset. Now, I've only spent a year or so dipping into this dataset, and there will likely be some of you with far more experience of it than me. But jokes aside, we do think it's capable of supporting decent analysis, and we're hoping to demonstrate that here. So the dataset was established in late 2017 and contains 150 plus variables spread across 30 tables, though only a handful are useful to ICBs really. And using it, perhaps unsurprisingly, given this diagram, it felt as though it felt as though it was probably optimized for database performance rather than analysis. But it has great potential to improve how community services are planned and how they're provided. Though no doubt at present its impact is limited by this lack of quality, completeness and coverage. But as I suggested earlier, if people don't use it, then it's unlikely to be developed. So I'd highly encourage you to consider using it if you have the opportunity. In any case, there are a few things to bear in mind if you are working with this data set, or indeed wanting to understand analysis based on this data, like I'm about to show. Firstly, there are thousands of providers of community services, big and small, but not all community service activity is captured by the CSDS. We believe that the vast majority of publicly funded contacts are recorded, but the activity of many small providers, often those from voluntary and private sectors with small contracts, is not recorded. Secondly, anyone attempting a basic study of community services will be hindered by the low quality of non-mandatory fields that are nonetheless pretty essential to an analysis. For example, in around 10% of cases, we cannot tell for sure whether a scheduled contact took place or not because the attendance status value is missing. And bulk returns can be pretty inconsistent, and they get more inconsistent the further back we look. For example, if I were to show monthly trends for a few of the larger providers in the Midlands, we see quite a lot of holes and anomalies, gaps and anomalies. The same is true for the Southwest. So due to limitations like this, our analysis was not quite as detailed or robust as we might have wished. But we're fairly content that our analysis provides a reasonable indication of the scale and distribution of services in the two regions we looked at. But our findings should also be interpreted with local contextual knowledge. Now, having said all that, I'll move on to what we looked at. Okay, so there are three parts to our work. Part one looked at how access to community services varied according to where an older person lives. This analysis was conducted at the regional level, so I'll take a quick look at some of the findings for the Midlands and then do the same for the Southwest. The latter two parts of this work use national data, so there's no need to deal with each region separately. Okay. Now, for the benefit of everyone, Midlanders or otherwise, the Midlands region is this yellow area. It extends from the Welsh border in the west to Lincolnshire in the east, and it covers cities such as Birmingham, Leicester, and Nottingham. In the calendar year 2022, community services commissioned by Midlands ICBs provided 9.2 million contacts to 500,000 individuals aged over 65. But in that year, how did access to community services vary across the region? Using standardized rates to account for differences in the age and sex structure of ICB populations, it appeared that ICBs with the highest community service contact rates were commissioning almost twice as many contacts per head as those with the lowest rates. So we saw a high of 5.5 contacts per head of the standardized population, and we saw a low of just over 3. Note that here we're talking about all types of contacts, face-to-face, telephone, video call, whatever. So you may notice that, generally speaking, those ICBs at the lower end of this distribution are those with a relatively high proportion of the are those in which a relatively high proportion of the population lives in a rural setting. The visits to rural communities are likely to require more person time and more resources than visits within urban or suburban areas. So we probably expect that ICBs with relatively large rural populations might at least have lower face-to-face contact rates than their peers. And if virtual contact rates were similar across the region, which I won't cover now, but this is covered in the report, then that might explain some of the difference. I should also mention here that a cyber attack in August of 2022 affected returns for some providers. So I therefore expect Herefordshire and Worcestershire's and Coventry and Warwickshire's rates to be about 10% higher than we see here. In any case, these overall rates are likely to hide important details. So we used the CSDS to look at other aspects of access and different ways in which ICBs allocated community service contacts. So let's imagine assigning patients to one of three groups based on their use of services in the year. So group 1 is for individuals with less than 5 contacts. Group 2 has between 6 and 24 contacts. And group 3 is for people who have 25 or more contacts. Now in 2022, depending on the ICB, individuals in group 3, that's this these bars on the right, represented between 10% and 27% of all persons in contact with community services. In terms of number of contacts, we calculated that this same hypervision group claimed between 66 and 82% of all consultations offered in an ICB. Now, if we were an ICB providing community services, one of the questions we might have is whether we should concentrate our limited resources on a smaller number of presumably high-need patients, or distribute these resources more widely. It appears that there was a range of responses to this question for Midlands ICBs, and incidentally, on further investigation, we found no firm evidence to suggest that allocation practices were linked to resource levels. Okay, then let's move on to look at the Southwest. So the Southwest region, this light blue area, extends from Gloucestershire and Wiltshire in the east to Cornwall and the Isles of Scilly in the west. It covers cities such as Bristol and Plymouth. There are also expanses of sparsely populated countryside. So for the Southwest, we looked at a 12-month period from October 22 to September 2023, in which data quality was consistently high for all but one ICB. So in this case, to overcome data quality issues, we were selective about the period we were looking at. But unfortunately, it made little sense to include Dorset in our analysis, as recorded contacts for Dorset were much lower than we'd expect given the ICB's size. So excluding Dorset, over this year period, community services commissioned by Southwest ICBs provided over 4 million contacts to 300,000 individuals aged 65 and over. Now, when we accounted for differences in the age and sex structure of ICB populations, we saw in general less variation than we did across the Midlands. The high was 4.5 contacts per head of standardised population, the low was 2.5. Now, Devon, I know, covers a large area and has many pretty isolated and rural communities, which could explain why its rates are lower. It could also be that a greater proportion of Devon's community services are provided by organisations who don't submit to the CSDS, or even that a contact is measured here slightly differently than in other places. Now, to this point, we've been looking at all consultations, face-to-face or otherwise, but what happens if we were to differentiate between mechanisms? So when we contrast ICB rates for all consultation mechanisms with rates for face-to-face consultations only, we see that Southwest ICBs with relatively high overall contact rates tend to have relatively low face-to-face contact rates and vice versa. Now, this might suggest that resource levels are in fact pretty similar across ICBs, but that some ICBs could be trading high face-to-face contact rates for high overall contact rates, and they do this by delivering more virtual contacts. From what we saw in the data, this tactic would be used to consolidate support for existing patients rather than to expand services to cover a larger number of patients. So that was a very quick look at geographical variation, and there's more detail for both regions in the forthcoming reports, but it does appear that access to community health services can vary considerably according to where an older person lives. The next part of our work looked at how access varies according to socio-demographic factors, that is specifically sex, ethnicity, and socio-economic group. Now, with this analysis, we took a slightly different approach. We looked at differences in access to face-to-face community services following hospital discharge. We linked the CSDS to the submitted patient care table, including patients aged over 65 and who were discharged from hospital in June or July of 2022. And we used data from ICBs across England. Now, whilst this post-discharge approach restricted the scope of our analysis some, it did allow us to make use of high-quality admissions data to better understand and control for difference in needs for a service. So this was another tactic we used. We employed variables from other data sets to overcome deficiencies in the CSDS. So using a logistic regression model, we estimated the odds of our population subgroups receiving a community service contact relative to a reference category. And we controlled for differences in need across 6 variables. So these were age, length of stay in hospital, the medical conditions a patient has, whether the patient was admitted on a planned or emergency basis, medical specialty that treated the patient, and the number of face-to-face contacts, community service contacts the patient received in the 30 days before admission. Results of the analysis suggested that women were marginally less likely to receive a face-to-face contact from community services within 30 days of discharge than men. So that was a 2.6% difference, and the effect is statistically significant. There was also variation in terms of equity of access by ethnicity. So compared to white British patients, those from some ethnic groups were significantly less likely to receive a face-to-face contact from community services within 30 days of discharge. So Bangladeshi patients were 32% less likely, Pakistani patients were 12% less likely, other Asian patients were 7% less likely, and Chinese patients 18% less likely to receive post-discharge contacts than their white British counterparts. Excuse me. So patients from other unnamed ethnicities or those whose ethnicity was not given or not known were also less likely to receive a community service contact after hospital discharge. And all other ethnic groups had levels of access that were not significantly different to those from the white British group. So we also found that in people living in more deprived areas are more likely to receive a face-to-face contact than community services from community services within 30 days of discharge than people living in less deprived areas. As we see here, there's a clear gradient to this effect, with people living in the least 2 deprived quintiles, around 13% less likely. So yeah, people living in the least deprived 2 quintiles, 13% less likely to receive a contact than those living in the most deprived areas. So we've seen here that access to community services can vary substantially by geographical area and across socio-demographic groups. In the final part of our analysis, we wanted to examine the potential consequences of unwarranted variation in access to services, community services. Now, I suggested earlier that community services may help to keep the wider health system working effectively. And Rachel, at this point, I wanted to conduct a quick survey, and there's no right or wrong answer. I'm just looking for your anonymous opinions, really. But are you able to share the Menti question, Rachel?
I am, indeed.
Should I stop sharing my screen, or?
No, I think I can just take it away from you, actually, just like that.
Okay.
Don't be insulted. So there we go. So that was, I think that was your question. You can, I'll leave you to ask the question that I've just popped on here.
Okay. So of all the people who answered, everyone has gone for decrease, and that's probably not.
Oh no, you're wrong.
Well, since I said that, someone's obviously say the same. Okay. Do I have to again share my slides, or? Okay,
so other people are contemplating, Andrew, and they're now thinking it's a trick question.
It's not a trick question. It's not.
I know. You've already explained. I know. I think so. You can see most people say they feel that there will be a decrease to or have the impact on urgent care services. So I think you can just share your screen, and I think it'll just overtake what I've got here.
Okay.
I mean, we've seen the results. I think they're quite clear what people think.
Thanks for that, Rachel, and thank you
for
everyone for sharing your opinions. So yeah, all else equal, it would be my prior opinion that if an ICB substantially increased its provision of community services, I'd expect demand for urgent care services in this ICB to decrease. So in addition to improving the lives of patients, the theory is that community services can decrease pressure on the urgent care system as the support they provide can reduce avoidable visits to urgent care services. And there's also the fact that community services support timely discharge of patients from hospital, but that's a topic for another huddle. Anyway, in order to understand some of the consequences of variation in access to community services, we wanted to investigate whether changes in the supply of community services do in fact lead to changes in demand for urgent care services. So our question more specifically was, did changes in the supply of community services between 2018 and the end of 2022 lead to changes in demand for urgent care services? Now, given that the indirect or direct aim of many community services is to reduce unnecessary admissions, we chose our primary urgent care outcome to be all-cause emergency admission rates. But since we couldn't rule out reverse causality, by which I mean the idea that changes in admission rates could actually influence provision of post-discharge community services, we examined several other alternative urgent care outcomes. And in these cases, for some of these, the direction of causation is more likely to be as we assumed. And we chose to conduct a panel regression analysis. So this is a population level this was a population level of approach. So our units of observation were geographical areas rather than patients. Now, Stephen has covered a panel regression approaches in a huddle a couple of years ago, but that's some time ago. To recap, panel regression will, by design, control for factors that vary over time, but are likely to remain consistent wherever you are. For example, national policy can vary over time, but likely to remain consistent wherever you are. It also controls for factors that vary by area, but remain fairly consistent over time, perhaps like healthcare seeking behaviour all levels of informal care. Now, due to the way the CSDS is structured and the time period we were looking at, we chose to examine geographical areas that were based on the footprints of 2018 CCGs. When we looked across England, we found 38 areas that did appear to have consistently high quality data. So that's another technique we use to get around data quality issues. We were selective about the areas we used and used those with good quality data. Now that's obviously not a random sample, so that has other problems. So these 38 areas covered about 1/5 of England's over 65 population. So we built a balanced panel data set that included measures of our 6 outcomes for these 38 geographical areas over 5 years. Now, I don't have a good way to illustrate this, but Rachel asked specifically if I'd cover some of the technical details, so I'll give a quick summary. Since our count, we use rate, and rate is a count of emissions divided by the population and year. But since our accounts of emissions or whatever were over dispersed, which means they have greater variability than would normally be expected for count data, we ran a negative binomial regression analysis using the R package LME4, which allowed us to do a panel regression type analysis with a little bit more flexibility than the typical panel regression package PLM. So our fixed effects were an area's community service contact rate, the year, the proportion of the area population aged 75 or over, and the area average income deprivation affecting older people index, and then we included area itself as a random effect, and this allowed us to control for factors that vary at random across geographical areas, and should therefore have enabled us to better estimate the effect of community service provision on our urgent care outcomes. So that's a bit about the technical details. So for context, over the study period, community service contact rates on aggregate dropped by 4%. That's this dark blue line here, showing the trend from 2018 to 2022. All-cause emergency admissions fell on aggregate, the dark red line here, by 8%. And these results seem to reflect the national picture over the period. As you can see with the lighter blue lines, one for each area, there was great variety in the trends for both community service contact rates and for all-cause emergency admission rates. So what did we observe in areas that had the largest decreases in community service contact rates? Well, surprisingly, our model suggested that areas with the largest decreases in contact rates tended to have the largest decreases in urgent care use. This effect was statistically significant, though it was small. So, for example, if community service provision was reduced by 10%, which would be a pretty large reduction, we might see all-cause emergency admissions decreased, but by only 1%. Emergency readmissions decreased, but by 2%, and A&E attendances decreased by 1.6%. Now, this ran counter to our expectations, and like many of you, Stephen and I assumed that a decrease in community contact rates would lead to an increase, or would have led to an increase in urgent care use, based on the same logic I covered a few minutes ago. But it's actually, it's actually not all that unusual that we find that our results confound our expectations. And perhaps we find no effect when we're expecting to find one. Or perhaps, like here, our findings run against our expectations, and then the work begins to understand why this might be the case. So let's first confront the obvious. There's the impact of data quality issues and then of the pandemic, which some of you might have noticed occurred right in the middle of our study period. And these will have undoubtedly affected our analysis to some degree. But because time is short, I'm going to step beyond data quality issues of data quality and then assume that data quality did not have a material effect on our findings. In this case, we might still point to several explanations for our results. So yes, they may be surprising results, but there is notable precedent for such findings. In fact, several UK-based studies investigating the effect of community service provision or other out-of-hospital activity on urgent care use actually reported comparable results. Now, a common explanation in these cases involves the idea that community and social care services continually identify unmet need in the population. So, for example, let's return to Jill. So a nurse has been visiting Jill for a month to monitor her COPD. Today, however, having taken the routine measurements, perhaps she notices that Jill has been gaining weight quite rapidly. Now, this can be an early indication of heart failure. So Jill is taken by her daughter to A&E and admitted to a hospital bed. Now, if community service contact rates were to fall, as we have seen in recent years, it may mean that these signs and the associated needs go unnoticed, and this in turn might result in reduced demand for urgent care. It's a fairly common notion that sort of more contact between individuals and healthcare professionals can result in more hospital activity, and presumably the opposite can also be true. So I've covered just a few of several explanations we have for these findings, and we can't, from our analysis, draw firm conclusions about the relationship between community service contacts and urgent care use. But our work suggests that the relationship could be more complex than the one we expected to find. Returning to the consequences of variation of access, it's possible then that ICBs with the highest community service contact rates may in fact see higher demand for urgent care services than those with lower rates. And this wouldn't necessarily be a bad thing. These extra community services could be identifying important and otherwise unmet need in the population. But if an ICB increases access rates to community services, it can't necessarily plan around the assumption that demand for urgent care services will fall. And in any case, this is an incentive for ICBs to continue to work closely with providers of community services to ensure that thresholds for escalation to hospital services are appropriately calibrated. So that's all I was going to cover today. I know that colleagues need a little bit of time towards the end of the session. I was also going to ask Stephen whether I'd missed anything in his opinion or anything important that needs addressing.
I think you covered it beautifully, Andrew. Nothing really to add from my perspective. Happy to help with answering questions if that's useful over the next few minutes before we close the call.
That would indeed be appreciated. Yes. Did you see any of the questions, Stephen? Or Were there any
no,
questions that
it's going to
came
be a
through?
huge surprise to all of you. Because my eyes only. There's a couple of questions and a couple of points, and I'll share my screen. And a couple have been answered as you've gone through your presentation anyway. So thank you very much, Andrew, for going through that. I enjoyed that presentation. And learning more about that data set and about these important relationships between community services and the acute sector. So one person, I'm jumping to the one on the right because this is the one I read last, and it was as you were saying it, in fact. So they'd responded to the previous question that they had anticipated an increase in acute activity, and this was why, as you've said, there's effectively more people out there to identify need. So it could be unmet need, so it could be indeed the right thing. So I've done that one for you.
Thank you.
But there's a more technical question top left, which I think we've got time to answer 2 or 3 of these. So this was about linking the CSDS to SUS. So what did you do? How did you do that?
There's a pseudonymized ID in both data sets that you can link on. Okay. I don't think any more is needed on that.
Okay, so it wasn't very clever. You just used the thing which is there specifically for that. No, that's fine. Okay, and then let's look at this one. So this one here. So does the CSDS have any information on outcomes of the visit? So, e.g., when a visit leads to an outcome of or urgent or emergency care. So is there an outcomes field?
I don't know that there is. Stephen, you might correct me, but I mean, you'd have to link it in order to find that out, I guess. Yeah.
Okay. So on the data set itself, it's hard to work out what happened after their sort of
So I mean, I wouldn't be too hopeful about. Yeah, I wouldn't be too hopeful about what information is actually provided. I mean, you can get away with the basics, but right now, yeah, there's not a huge amount of consistency with other variables.
Can I come in on that point?
A myriad of services. Yeah, sure, Stephen.
So in the CSDS, in Andrew's analysis, we were relying on a relatively small number of fields that seemed reasonably well coded. Okay. But there were a handful of other fields that we would love to have used, which would have given us much more insight. And at the moment, community service providers, what they get from NHS Digital is a data quality report every month, telling them all the errors or all the missing data in all of the fields across the various tables, but no sense of priority about which ones they should focus on. Okay. And the data set is so large and complex, you can imagine it's a daunting task for providers. So one of the things that we do in the report is to suggest to commissioners and to providers that there are a handful of fields that would be great to get to improve the data quality on next. Those are the ones we think should reserve extra attention in data quality improvement efforts, because we think that will help us use the data sets and build confidence in it further. So yeah, I can't quite remember what the fields are now, but there was fields like, for example, whether the attendance took place or not. Yeah. Who provided the contact? It'd be great to know, for example, whether these contacts are provided by nurses or physios or other therapists or other types of healthcare professionals. And again, that field isn't particularly well recorded at the moment in CSDS, and to get data quality improvements on that field would be incredibly useful. So yeah, we have some recommendations in the report for ICBs and providers about where to look next to improve the data quality of their submissions.
Okay, thanks, Stephen. It sounds like that would be really helpful and may go some way to improve the data set overall, which is what we want. We want people to use it, improve it, and then use it more. So the question I've highlighted here was, have you done any separate analyses on the impact of ethnicity versus deprivation? So have you done any further work on those two variants?
Shall I pick that one up as well, Andrew?
Yes, right? Please. Yeah.
So in the analysis we did, when we did the equity analysis by ethnicity, we were controlling for variation in deprivation and sex and age and various other variables as well. So we were trying to identify, it is true that ethnicity and deprivation are linked together, Many ethnic minority communities tend to live in more deprived areas. But in our analysis, we attempted to strip that effect out by looking just for ethnicity, having control for differences in age, sex, deprivation, for example. So I think that answers the question. There is another way to look at this, which is to say, does the effect of deprivation have a different effect on white people than it does on, for example, Bangladeshi people, with respect to community service contacts after discharge? And that's a slightly more complex question, which we didn't go into, but it is amenable to analysis, I think, from the data sets we had.
Okay. So we're a little bit pushed for time because I'm going to hand over to Jen in a minute, but there's some really great questions here. So if we could just pick maybe just a couple more, then if it's okay with you, if I share these with you afterwards, because I think these are really useful questions to share or points to share, and we can put the responses on the website alongside the video afterwards, so people can make sure they got a response. So there's just a point here that which is asking, do we think, and we don't know, but do we think in fact that community staff refer to urgent care because of delays in seeing GPs? Any evidence of that?
We haven't. I wouldn't say we have evidence for it, but it's a good. Sounds like a sound theory to me.
Yeah.
I think one of the things about working in community settings is that you often, as a practitioner, I imagine, feel isolated enough, and you have to make clinical decisions, without an awful lot of support around you, and that will lead to more risk-averse decision making almost inevitably, unless people have access to other places where they can get greater degree of confidence on their clinical decision making, like GPs or consultants, for example, in hospital. So lack of access to those things is almost bound to increase risk-averse behaviours and increase admissions, I would have thought. And we know how access to GPs is going at the moment, don't we?
Yeah, shooting down, isn't it? That's what. You no one goes to the GPs anymore. No, yes, we have to look at things as a whole as well. Someone's made a comment here about virtual ward activity, and that it's often CSDS, even though it shouldn't be, and those patients could be skewing this. Might that be an aspect?
Yeah, that's another the virtual ward initiatives. The way in which they're defined and counted, I think, is a bit of a mixed bag at the moment, and I think that is a potential. Has potential to bias the results, certainly. I think that's something we'll get tighter on over the next few years, I guess, as virtual wards become more sort of commonplace and formal part of our healthcare systems. But I can imagine at the moment there is variation in recording of processes for those. Okay,
so I'm going to pause there, and people are still sort of making some further comments, and we won't lose these observations and questions. As I said, we'll collate them together, respond to them, and put them on the website. Or I'll probably email them out afterwards. So I'd thank you very much, Andrew and Stephen, for sharing that with us. And it's sort of given us a lot of insight into that data set in particular, and its usage, its limitations, and so on, and the relationship with the acute sector activity as well. And I can see that Claire just put her hand up, so I'm gonna.
Accident. Sorry.
Oh, was it?
I was trying to do the reaction and I pressed the wrong button. My bad.
Oh, Claire, I call that attention seeking, but that's absolutely fine. So yeah, thank you very much. We'll definitely do a follow up, and I think this report will be available in the next few weeks. I think it's going to be published in the next few weeks. It's my understanding. So I would now like to hand over to Jen and Claire, which is Jen, I can't see Claire. And I've so as the work that you mentioned at the beginning, and we've come back to, there's a couple of questions, or this question that we put at the end as well. So if you Jen would like to say just a little bit more about the project that you're working on, and how you think these people can help you do your job, and also get something out of it.
Yeah, I think that getting something out of it thing is something that's quite important. So we are,
sure.
I'm particularly interested in those people who are interested in modelling future community services demand. When we came into this, we know that we want to do some work on this. We know that we have a couple of ICPs or trusts who are also interested in it. that we're talking about how they think about these things. We wanted an analyst perspective, and we wanted to think about understanding how you might want to use this data in this way, and what questions you're trying to ask, and trying to think a bit more about how we might solve some of these problems collectively or together. So basically, it's not a we're not asking for a huge amount of time or energy, but if you could either let Rachel know or me know if you want to have a further conversation about these things, and depending, well, we'll probably have an individual chat with any of you who've put yourselves forward, and have a think about then what we do with that, and whether there's something we can kind of put a group together, or send you our kind of findings and learnings as we go along, or take your input into the work that we're doing and see if there's something that we can pass back to you as the project progresses. So yeah, a bit of an opportunity, and hopefully something that will be useful, and we will occasionally be tapping into the experience that the strategy unit has had in dealing with or understanding these data qualities and the structure of this data set as well, and other ways of trying to look at it. On the other hand, I'm not promising bells and whistles or that we've solved the world or that you're but yeah, it would be great if you could get in touch. And that's it really, I think.
No, that's absolutely fine. I think we talked about maybe so we've got lots of people here today, but there's a lot more out there who in the Analyst network who may want to be part of this or contribute to this or learn from this process. So we thought about just doing a very, very quick survey that we could send out after, didn't we, just to make sure that we've captured those who are interested in learning more or participating in these kind of activities. And I think, you know, modelling, anything to do with community services feels complicated, because guess what, it is, but it's so important, and the more we look at it, the more questions it raises, but the more we understand those complexities and the relationships between the different services and the relationship with the acute sector as well, and other services. So this is it's fascinating work, it's interesting work. I've had sort of close connections with bits of it, and it is very, very interesting. So I will do that after the session today, Jenny, and I'll link. This recording will be on the website as usual. I'll encourage Andrew and Stephen to respond to the unanswered questions, and so everything will be finished. I'll be able to just say tick. So I would very much like to. I'll just stop sharing actually. So I've said stop sharing. That's a silly thing to do. I want to actually now share again, exactly the same thing. Oh, so unprofessional. Come on, Caswell, get your act together. So I just want to say, yep, coming up, we've got some fantastic huddles coming up. In fact, this is going to be a really interesting one. These aren't in the right order, and I know I promised last time to put them on the website. And I haven't, so but I will with some dates, because they are all booked in. So there's some really great ones coming up soon, and there are also some training opportunities for you to look forward to in our new development regime, which is coming soon. And just in case you haven't already, make sure you get booked onto Hacker 2024, because tickets are selling fast, and I don't want you to miss out. And I am giving you preferential treatment. And before I go, because it is 12, I meant to say welcome to anybody who's joined us from the Southwest. And I wondered if any of them had been on the Leadership Development for Analysts course and had seen this face before. You're very welcome, and you're welcome to come any time to come, because you got a special mention today. So thank you Andrew, thank you Stephen, thank you Jen, and thank you everyone for coming, and we'll see you in a couple of weeks. Bye.